over enough of it so that you'll help you. All right, did everybody get confidentiality form? Did everybody get a copy? We need a copy. No confidentiality form? All right, so help y'all have the line out. All right, y'all, on page 181. So, 77% of adults diagnosed with psychiatric disorders were first diagnosed between the ages of 11 and 18. Disruption to normal pattern of childhood development. So what you're seeing, like y'all in pediatrics, y'all learned the developmental milestones. So you see a difference in that. You see a change in what they used to do. That's a regression. So you're using your developmental milestones when you're studying children. The outpatient child and adolescent program, the Aspire, is during the week. So you really want to be able to see that. But and see, they have children come in for clubhouse. They have children come after school, and then what a lot of the counselors do is go into the schools to do a lot of the individual one-on-one counseling that takes place. So there's a lot of resources available if the families are aware of it. So this is one of your roles as a nurse, to teach and to tell others about what resources are available. It is difficult to diagnose in young children, and then there's a lack of services and premature termination of treatment. Oh, I already said all that. Sorry, y'all. All right, because of their timing, these psychiatric disorders can disrupt the normal pattern of childhood development. So these disorders not only affect the child, but also can cause significant stress for families and disrupt family function. And there's the stigma that we've already talked about is there, especially with children. Mamas always feel it's always the mama's fault. Or we always feel like it's our fault when something's going on. And difficulties with the children. It says that lack of services and premature termination of treatment are two main problems, especially for the vulnerable populations. And this is your poor children with single mothers, minority children, and those with serious presenting problems with mental. So I'm still on page 182. All right, your book goes into the etiology, the cause. All right. There is a genetic vulnerability coupled with the parents' inability to model effective coping strategies. That can lead to learned helplessness, creating anxiety or apathy, and an inability to master the environment. All right, this is the Jones spot. Somebody's going to have to answer me. What have you seen in your nursing career as a student? Because I'm sure you've seen it. Have you seen parents who did not model effective coping strategies? whether it was in peds, whether it was in, even on a med surg, you could never seen it. All right, think back to that. All right, think back to, all right, how do some parents handle stress? I'm talking about everything. Oh, I'm not sure. Not that. Just So see, some people use alcohol, some people use the drugs, What about the mother that, or the dad, that just, handles difficulties in life by yelling and screaming? Is that a good role model? Or even if the child sees eating in the home, the child sees slapping, that's a learned behavior. So, a lot of times you have to stop and think when you see children, behaving the way they are. Some of it is learned. So see, it's not just genetics. That's why I highlight this. We need to effectively, and I'm not saying we're perfect, because there's probably not a one of y'all, not a one of us, any of us that are perfect. We all have bad days. If your child knows you love them, that's different. They'll love you. Just like when you get upset with your dog wants to love you. So but when you apologize to your child, I say that is a wonderful learned coping skill. But it does, if they're not trained in effective coping strategies, it means you learn helplessness, creating anxiety or apathy, the inability to master the environment. All right, genetics. This talks about your hereditary factors. So it says it's implicated in numerous childhood onset. And then it's assumed that factors such as resilience, intelligence, and supportive environment aid in avoiding the development of mental disorders. All right, now we talked about resilience. I'm not sure if you remember, but that's just like, you've got 4 children that live in a home where the father or the mother are alcoholics. So of the 4 children, there's going to be there could easily be 4 of them that are resilient and say, I will never touch a drug, and they're resilient. That's that resilience, it's that inner core that they have in themselves. Now, there may be some of them that do use drugs, and you could blame the genetics, you could say that, and it could be, but that's what resilience is. That's that child that says, I'm going to do that. All right, neurobiological dramatic changes occur in the brain during childhood and adolescence, including a declining number of synapses. They peak at age 5. The teen years are also marked by changes in the frontal and the prefrontal cortex region, leading to improvements in executive functioning. Remember that your frontal lobe is the one that handles your emotions. Planning skills and hitting responses. Your psychological factors. This is your temperament. This is the style of behavior a child habitually uses to cope with the demands and expectations of the environment. So remember from way back in the first few chapters when we talked about flaws and the people that thought your personality was developed right at a young age. The caregiver's role in shaping the relationship is of primary importance, and the nurse can intervene to teach parents ways to modify their behaviors to improve the interaction. Back in the day when I was in high school, we had parenting classes, and I know when my children they still taught parenting, and I was one of the ones that I really think every child should take parenting classes. male and female, because it's, you know, we don't all have the role models that we wish we had. So, that is something you know, we as nurses can help push for good, you know, good changes. By the time children enter grade school, temperament and behavior traits can be powerful predictors. So these traits, of course, include the shyness, the aggressiveness, the rebelliousness. And external risk factors for substance abuse include peer or parental substance use. We've already talked about resilience. That's the phenomenon of resilience. Describes the relationship with a child's inborn strength and that child's success in handling stress. Environmental factors. During childhood, the main context is the family. Parents model behavior, provide the child with a view of the world. So allow your child to make choices. You know, don't always tell them what they have to do. And this is how you teach patients, you know, teach parents. You know, allow your child to make choices. Don't tell them it's time for bath. Tell them, you know, you're going to take a bath before, whatever, or after. You know, before, what do you say? Before I read a book or after I read a book. You know, something like that. So you give them a choice. Are you going to wear these pants or these? So you're giving them choices. Risk factors include severe marital discord. So of course, if there's problems in the home, low socioeconomic status, large families, overcrowding, parental criminality, maternal and psychiatric disorders, and foster care placement. Witnessing violence is traumatizing, so it's a well-documented risk factor for many mental health problems. This is your depression, your anxiety, your PTSD, aggressive and delinquent behavior. So these are the risk factors. I'm sorry, I underlined a lot of this stuff. Children who have experienced abuse are at risk for identifying with their aggressor and may act out, bully others, become abusers, or develop dysfunctional interpersonal relationships in adulthood. C, and neglect. Neglect is the most prevalent form of child abuse in the United States. And there are 1.7 million reports of child abuse and neglect in 2010. And then there's the bullying. Bullying is also a risk factor for such problems as depression and suicide disorder. So, 13-year-old girl, Friday, and she had posted on her Facebook, social media, that she was going to commit suicide. And apparently, see, I don't know this. Y'all can just talk into the Facebook to your phone, and they'll just type what you say. Is that right? So if she didn't read that what she had quote said. But anyway, she ended up saying it was because she was being bullied, and that she really was not having plans to hurt herself. But she is getting some help. Her mother is on drugs, so she's being raised by her grandmother. So bullying is also a risk factor for such problems as depression and suicide disorder. Then your next page goes into cyberbullying. There's still some debate on cyberbullying, but there is still, this is in this health policy section on page 184. So the effects of forms of bullying are in the damagingness that done face to face and can have severe emotional consequences. And then culture, there's just difference in culture expectations. So you just have to kind of know your culture. So differences in culture expectations may affect the child. All right, a child with many risk factors for the development of mental illness develops normally. You hear the term resilience used. What is the characteristics? I think we want to. So the child is able to adapt to changes in the environment. The child has the ability to form nurturing relationships with other adults when the parent is not available. The ability to distance self from emotional chaos. A good social intelligence, good problem-solving skills, ability to perceive a long-term future. So, you know, that's why it's so important to be kind, you know, to anybody in the hospital, to give them the respect, because you never know what's going on at home. So what are some of the familiar risk factors we've already talked about? The severe marital discord, the low socioeconomic status, the large families, overcrowded, the parents in jail. Maternal psychiatric disorders, foster care. And then there's the other factors we've talked about, that's the witness and violence, the children have experienced abuse and bullying. All right, assessing development and functioning. All right, so this is the child or adolescent with mental illness is one whose progressive personality development and functions are hindered, so I'm on page 185. So if you look in that table, that box 11.1, characteristics of a mentally healthy child or adolescent. Trust others. Remember from way back in your, what was that we talked about? And the bottom layer, and you have to develop that trust as a child, as a Maslow. So trust others and sees his or her world as being safe and supported. Correctly interprets reality, makes accurate perceptions. So this is a mentally healthy child or adolescent. Box 11.2 identifies essential assessment data. So that's the next page. That's your current, that y'all do the assessments. This is your history of present illness, developmental history, developmental assessment, neurological assessment. That's what the mental status exam you're going to be looking at, the neurological assessment, medical history, family history, mental status assessment. So how do you collect that? Y'all already know how to do it. So histories are taken from the family, from the teachers at school. I'm going to turn this one down. Let's see. Is that Bobby on? All right, go back on 189. Let's make sure the developmental assessment. So this just tells you the child's or adolescent's maturation level. So it's in relation to the child's chronological age, to look at the developmental strengths and deficits. And risk behavior survey for children and adolescents is conducted annually by the CDC. So abnormal findings in the developmental and mental status assessment may be related to stress and adjustment problems. This is your use of maladaptive coping behaviors. Increases the risk of developing mental disorders. All right, general interventions for the children and adolescents. So family group. Critical to improving the function of a young person with a psychiatric illness. So family counseling is often a key component of treatment. Now, how many of y'all would like to do something like that? Sit down with the families and be a, it's if you as an RN have learned to do groups. You as an RN, if you had some experience, can learn are to do things like this. They did not begin to say like that. And so what you do is you allow the family to discuss. And hopefully, you do, like I said, since you're doing homework assignments, to practice newly learned skills outside the therapy environment. You learn how other family therapy may prove useful. You learn how other families solve problems and build on strengths. Like group therapy. Group therapy would be like what divorce support groups. For younger children, it may be they get together as a group, and it's the play therapy. For grade school children, it combines play, learning skills, and talking about the activity. Behavioral therapy. This is your behavior modification. Involves rewarding desired behavior to reduce maladaptive behaviors. Remember, you want to go the principle of least restrictive intervention. So we use, nothing in seclusion unless that's the last thing we do. So most children and adolescent treatment settings use a behavior modification program to motivate and reward age-appropriate behaviors. That's the point and level system. You have to earn your way. You get so many points for doing what you're supposed to do, following the rules. So that's why you're very specific on what their expectations are. You can always do this in your home. You remember the chores. You give them a point. If you make so many points at the end of the week, then you get a treat. Cognitive behavior therapy is an evidence-based treatment approach. It's based on the premise that negative and self-defeating thoughts lead to psychiatric pathology. So, cognitive behavior therapy is successful in treating children with anxiety or depressive disorders. So you're teaching the children what to do when they get anxious. Disruptive behavior management. It says, as controversy continues over the use of locked seclusion rooms and physical restraint in managing dangerous behaviors, evidence suggests that both psychologically harmful and can be physically harmful, and deaths have occurred. So all members of the treatment team who use therapy holding, locked seclusions, or physical restraint of children and adolescents must receive training to decrease the risk of injury to the young person. The Centers of Medicare and Medicaid, state mental health acts, professional nursing organizations have set guidelines for seclusion, same as with restraints. These interventions require prompt, firm, non-retaliatory protective restraint that is gentle and safe, reduces the risk of injury to self or others. So it is a learned behavior for the staff, because you have to learn how not to get emotionally involved. And your tone of voice has to stay the same. You can't be like the mom. You have to just stay calm and set the tone. Remind the child over and over that you're protecting them. You don't want to hurt them, but you just want to protect them from hurting themselves. Did y'all talk about this in orientation at all? Explain. What y'all did with it? Not so about children. Oh, that's right. Y'all already had adults. That's true. So what did y'all learn? Oh, you want to say well,
whatever clinical paperwork.
oh, okay, y'all did the side.
Okay, that's all I did.
All right. The decision to restrain or seclude a child is often made by the registered nurse who's working with the patient. All patients in seclusion or restraints must be monitored constantly. Vital signs, range of motion every 15 minutes, hydration, elimination, comfort, and other psychological physical needs should be monitored. So remember from the other chapters we've had, that you want to document that you offer something to drink. Once the child is calm, the staff should discuss what happened with the patient. This helps to strengthen the nurse-patient relationship. Like time out. So asking or directing a child or adolescent to take a time out is used to halt disruptive behavior, allow for self-reflection, encourages self-control. It is found to be less restrictive than seclusion. So time out is just putting in the periphery of the room. So the quiet room is an unlocked quiet room for a child that is an area of the decreased stimulation to regain and maintain self-control. Some of your kindergarten rooms have got an area in the corner that's considered a quiet area where they can go and sit away and secludedly. It's not necessarily used as a timeout, maybe, but technically it's supposed to help them as a quiet time. This is like a sensory time. It says under the quiet room, you may have maybe a sensory room that contains items of relaxation, meditation, music, yoga. Play therapy. Play is often described as the work of childhood through which the children learn to master impulses. So play therapy can be used to teach children. It includes art supplies, play or Play-Doh, dolls and dollhouses, hand puppets, toys. You probably saw that in pediatrics when y'all had the play areas for kids. All right, they show you these little examples. Levi, as a school-age child, was admitted to the hospital from his foster home placement. He's been in foster care since his mother died from a drug overdose. His father is currently incarcerated for robbery and drug-related offenses. He has a history of self-injurious behavior. This includes biting and pinching himself and hitting his head against the wall. When he's frustrated, the nurse at activity therapy have worked to teach him to request time in the sensory room when he begins to feel upset or anxious. He has been able to identify certain triggers and to request time in the sensory room, decreasing his episodes of self-injury. How sad is that? So you teach them, and you have to just be really respectful, and it takes a special person to do this. The bibliography. This is bibliotherapy. Sorry, y'all. It just says this is a involved literature. Stories and books should be used to reflect the situations or feelings. So what you just go to the library and find is ask for different books that may help. It's a way of helping the kids, the students, not the students, the children. Therapeutic drawing. Nonverbal meaning expressing difficult to confuse emotions. Journaling is just that, it's writing. Music therapy, the healing power of music. All right, psychopharmacology, your meds. Medicating children typically works best when combined with another treatment such as cognitive behavior therapy. So meds that target specific symptoms can make a real difference in a family's ability to cope. Teamwork and safety. This is why you have your team meetings. And so you'll see this when you go to site. You'll see them sitting around and discussing the patient. So everybody's kind of on the same plane. All right, speech disorders have to do with problems in making sounds. This is your communication disorders. They may distort, add, or omit sounds. They may note disturbances in the fluency, such as a stutter. So language disorders result in difficulty understanding and seen or evident of the inability to follow directions. Expressive language disorder is impairment in the ability to develop skills to communicate verbally or through sign language. So the child or teen may have problems relating with other people. Social communication disorders, problems using verbal and nonverbal means, interacting with others. So causes of learning of language disorders. First, you always check out the hearing loss. Neurological disorders, intellectual disabilities, drug abuse, brain injury, physical problems such as a cleft palate. Disability Education Act provides early intervention services for every state for toddlers up to age 3. So this is a mandate. So remember, have y'all seen babies that have checked for hearing? Learning disorders. So this is just the definitions, dyslexia. And these are identified during school years. They're diagnosed when a child demonstrates persistent difficulty in acquiring reading, math, or written expression. So the diagnosis is made through the evaluation of multiple assessments. Screenings for learning disorders is essential for early interventions that may be beneficial. Long-term outcomes for children include low self-esteem, poor social skills, higher rates of dropout, difficulties with attaining and maintaining employment, and poor social adjustment. So learning disorders is very important to catch early. All right, your motor disorders. All right, there's two big lists here: your stereotypic movement disorder and your Tourette's disorder. So this is your, so what you're doing when you do the Denver Developmental Study is you're looking at gross or fine motor skills for children in the coordination. So what is your stereotypical? This is manifested through repetitive, purposeless movements, hand waving, rocking, head banging, nail biting, for a period of 4 weeks or greater. Now, Tourette's. Right, Tourette's says it's more common in boys than in girls. It's like a tic disorder. Y'all ever seen that with Tourette's? So it's something that is, it says the disorder is usually permanent. There may be periods of remission. Symptoms often diminish during adolescence and sometimes disappear by early adulthood. Tourette disorders may often coexist with depression, obsessive compulsive disorder, attention deficit. Tourette's disorder is characterized by motor and verbal tics between the ages of 2 and 7. The verbal tic, that would be somebody that just sitting still and then all of a sudden just yelling. It can be extremely embarrassing, but then look here, the only drugs that FDA approved for treating tics is with Tourette's disorder is Haldol, or your conventional antipsychotic. And that would be your first generation. It says Abilify is an atypical antipsychotic has been used in investigation. Clonidine. Y'all all probably have given clonidine, or have y'all seen it or studied it already? Y'all already got hypertension. So clonidine is used in adults for blood pressure. So we use it in children for alpha-2 adrenergic agonist is used for hypertension, is used for tics. It's also used for sleep for children. It's also used for ADHD for children. And it's also used for, like to take your, condom. Alright, an anti-anxiety drug, clonidine, may be used. Well, your book didn't really go, I mean, this didn't really go into intellectual development disorder. So let me talk just briefly about it, because I guess it's on the handout. Or is it? Oh, it is, it's right there, I just looked at it. I'm sorry, there it is. So intellectual development disorder, what we can call mentally retarded or developmental disability, now it's called intellectual development disorder, IDD. So the first intellectual functioning is characterized by deficits in reasoning, problem solving, planning, judgment. The second is social functioning, impaired terms in communication and language. Finally, practical aspects of daily life are impacted by deficit in managing age-appropriate activities of daily living. So, for IDD or the motor disorders, or learning disorders, you know, none of those are caused by parents or caused by something, you know, it's usually something that's genetic or usually something that may have happened. There may be some intellectual development, and may have been some damage at birth, some, you know, anoxia. So sometimes children are affected by that, but with intellectual development, it's usually hereditary factors, chromosomal disorders. So all I'm getting at is, you teach the family what's the cause. You know, don't blame yourself. So the child with IDD has impairments in conceptual, social, practical functioning ranging from mild to severe. So the severity and evidence in the ability to communicate effectively, meet one's own self-needs, safety needs, socialize in an age-appropriate manner. Outcome identification. You see that's on page 191, engaging in simple social interactions and accepting assistance or feedback regarding behavior without frustration. Tolerating social interactions for short periods of time without becoming disruptive or frustrating. Early intervention programs or public school programs, you know, once they reach a certain age, the schools have to provide some assistance with the federal legislation. Public schools provide services to assist children with emotional and developmental disorders to participate in school. Treatment plans are individualized and realistic. Strength-based perception on the evaluation is the assessment. We identify both the areas of need and the capabilities, focusing on to maximize the family resources and link to services. So your families need a lot of support too, and not just the children. So you need to teach the families the support systems that are there. Hook them up with Easter seal if you can to teach so that family members can learn how to take care of the patient. Autism spectrum. Autism spectrum is like an IDD. It's from mild to severe. It's complex neurobiological developmental disability. Typically appear during a child's first 3 years of life. Autism affects the normal development of the brain and social interaction and communication skills. Just like IDD, it ranges from mild to severe. Symptoms include deficits in social relatedness, include communication, nonverbal behavior, age-appropriate interactions. Other behaviors include stereotypical repetitive speech, use of objects, over-adherence to routines or rituals. So some of them are obsessive compulsive fixations with particular objects. They have to have something just right, and so if you think about with the children, remember that, they also age, and so you see, the developmental disabilities with people that are 60 years old. So it becomes a long-term lifestyle change for the families. We've got some families that the man is in his, he's in his 70s, and he's got some health issues, but he's got a young 40-year-old, he's a deaf mute. And you always wonder, and sometimes I'll ask, you made some plans. One is an 88-year-old lady, y'all. She's got at least 5 that live in her house, and schizophrenia, and I just wonder what is going to happen to that family, one day. So it is a lifestyle change when you see mental issues. The stroke becomes a lifestyle change too, but sometimes that gets better. Sometimes it stays the same. All right. Autism spectrum, the assessment of it. The book goes into it. Just once again, you're talking about developmental delays, the diagnosis, the early intervention programs that are available. Legalities are mandated under the Children with Disabilities Act. Treatment plans include behavior management, reward system. So you need that consistency, teaching parents to provide structure, the rewards, the consistency of the rules, the expectations at home, and shape and modify the behavior, foster the development. Children with autism may receive physical, occupational speech therapy as part of their plan. And so the individuals and family strengths need to be considered. All right, medications. They to target the specific symptoms. Decrease the anxiety, compulsive behaviors, agitation. All right, so that's Risperdal, and that olanzapine, that is Zyprexa. I don't know how you pronounce it, but Wildtime, that's Seroquel. Umeprazole, that's your Abilify. So they've been seen to reduce harmful behavior. The SSRIs are the most popular psychotropic agent used in the population, improving mood and reducing anxiety. So the SSRIs, that's your Zoloft, that's your Paxil. All right, so the evaluation will be individualized, use a strength-based perspective, assist in the multidisciplinary team. Now ADHD, let me tell y'all this real quick while I'm thinking about it. I live close to Bluffton, okay, and Bluffton has got white oak pastures, that's the organic, and the way of slaughtering animals in a humane way. So Temple Rhonda is has autism, and she is the one that developed the humane system for slaughtering cattle and relieving stress for the autistic children. That was kind of interesting. So if you go and make a little tour, it's kind of interesting to go. They'll tell you how they do it. They bring the cows at night so that they have time to settle down. And they don't have them on everything. They don't have, I can't remember that. Maybe they're not used to being on cement, so they bring them the night before so they get used to, they're on the cement long enough to get settled. And so they bring them in and they zap them. So there's supposed to be a way of zapping them so that it doesn't hurt. This came from her. They researched her Temple Grandin, Grandin. So it's kind of interesting to see. So autism, y'all may know some people that have little quirks, they're just a little different, so that may be autism on the lower stand. Sometimes they're extremely bright, and some autism have very wonderful music. Because I've had patients tell me that they don't want to be on some of the medicines because they lose the ability to draw. Or they lose the ability to write in journals. So, all right, sorry, I got sidetracked. Where are we? Done? Autism. So ADHD. All right, ADHD. This is your attention deficit hyperactivity disorder. It's an inappropriate degree of inattention and compulsive hyperactivity. You have to have, in order to diagnose a child with ADHD symptoms, you have at least 2 settings, the home and the school. So you cannot, the physician cannot just look at what the mother says, or what the family says. And you can't just look at what the school says. You have to look at both. And it usually occurs before age 12. And it's usually detected when a child has difficulty adjusting to elementary school. Scroll on down, median age is age 7. It includes hyperactivity, difficulty taking turns, maintaining social relationships, high levels of impulsivity, poor social boundaries, intrusive behaviors, frequently interrupting others. They have low self-esteem. So assessment, you observe level of physical activity, attention span, talkativeness. Sometimes you wonder, is ADHD overdiagnosed? All right, so the diagnosis can be, like we've already said, it can be overactive, it can be disruptive behaviors that are impulsive, angry, aggressive, often dangerous. In addition, their behaviors negative impact their ability to develop with their peers and family relationships. So so because of their ADHD, they will have difficulty having friends and having closeness with the family. They get along with their children, their brothers and sisters. So outcome identified. The target, the hyperactivity, impulsive, self-control, development of self-identity, self-esteem, positive coping skills. So you want to teach them how to handle it. So implementation. Focus on correcting the faulty personality, which includes firmly entrenched patterns such as blaming others and denial of responsibility for their actions. You have to control aggressive behavior. Meds may be used, including antipsychotics, lithium, anticonvulsants, antidepressants. There are psychostimulants such as are dose-dependent, low dose stimulate aggressive behaviors, while moderate to high dose suppress aggression. Alright, so once we get into the schizophrenia, we'll go closer deeper into the drugs and the side effects and what you look for. Mood stabilizers. This is your lithium. The anticonvulsants reduce aggressive behavior, mood lability. Your quantity is used for reducing agitation and rage and increasing frustration tolerance. And then you have the risk of tardive dyskinesia with long-term use of antipsychotics. Still can't stress enough of therapy. The cognitive behavior therapy is used to change the pattern of misconduct. So still, sometimes psychiatrist offices may not have counselors. So you may want to encourage your, may just tell your patient that there are other resources that your child may want to check into. Because the counseling may help. you have a really good child counselor. And they're the ones that teach this cognitive behavior therapy. So you teach the parents how to set limits, how to be consistent with the rules and consistent with the care. They're taught techniques for modifying the behavior, monitoring medications. All right, so for ADHD, your drugs, your pharmacology. And this is your Ritalin and your Adderall, the most widely used stimulants because of their relative safety, simplicity. Insomnia is a common side effect. If you keep going down that same little paragraph, other common side effects include appetite suppressant, headaches, abdominal pain, lethargy. So you always want to check weights. Now remember that Ritalin and Adderall are control drugs. You have to have a hard copy prescription written. So when they come, you need to get their height, their weight, plot them on the graph so that you get the CDC that shows how they are on the growth chart. Other common side effects, remember, is appetite suppressant, the headaches, the abdominal pain, lethargy. So sometimes the insomnia. So ask me that. Strattera is approved for childhood as a non-stimulant for ADHD. Therapeutic responses develop slowly. It may take up to 6 weeks for full improvement. Box 11.3 gives you some techniques for managing disruptive behavior. You see the third one down, the modeling. So the observation is very important. Planned ignoring. So that's when you deliberately don't see what the child is doing. Limit settings involves giving direction, setting an expectation. Redirection. This is when you redirect them to do something else. All right, evaluation. For the family and child with ADHD, evaluation will focus on the symptom pattern, the severity. So you want to look at, of course, you want to know how the grades are doing, how they're doing at home, social relationships, playing with other children, okay, So aggressive behaviors, what do you treat it with? You can go back to part. Antipsychotics, and antidepressants. Low dose stimulants may stimulate aggressive behaviors, while moderate to high dose may suppress aggression. All right, which statement demonstrates that a parent understands the diagnosis of attention deficit? What y'all say, A? Okay, all right. Which statement? All right. I guess that's what I have done. Which child would be most difficult to diagnose? What name is giving us a rationale?
Maybe those are other options.
Oh, okay. All right, which child would be most difficult to diagnose from neural development? The other children are more difficult to diagnose. They're limited language skills. All right, 4-year-old limited lashes out. That's right, so it's B. All right, schizophrenia then, y'all y'all, schizophrenia is, it's like, even though y'all are getting topics that you have, that you can put your finger on better than some of this other stuff we talked about, it's still, still hard to me. It's just hard. Schizophrenia is a spectrum, disturbs the fundamental ability to determine what is and is not real. So if you look at that box on page 12, it shows you the psychotic disorders, maybe schizophrenia, and it's listed as from least to the worst. That's how they say it's explained. So the most severe disorder of this category is schizophrenia, and it's the major focus of the chapter. Schizophrenia is a potentially devastating brain disorder that affects a person's thinking, language, emotions, social behavior, ability to perceive reality accurately. It affects over 3.5 million persons in the United States. And it says the clinical picture, the patients present themselves as different, maybe first as at school, they may not do as well with their siblings, less socially engaged, less positive. And see, adolescents who are later diagnosed with schizophrenia often experience prodromal symptoms. Next page. It says that all people diagnosed with schizophrenia have at least one psychotic symptom, such as hallucinations, delusions, or disorganized speech. It's diagnosed more frequently in males. It's funny how it says it's growing up in urban areas. Schizophrenia usually presents during the late teens and early 20s. So a lot of times you'll see it for patients who are, for teenagers who go off to college and there's a sudden change in their lifestyle, or they go off into service, and so there's a definite change. So early onset schizophrenia is 18 to 25, more often occurs in males. See, just keep telling yourself it's a structural brain abnormality. Increased levels of apathy. And then it says that later on, say 25 to 35, may be seen with women. Comorbidity. Substance abuse disorders occur in nearly 50% of persons with schizophrenia associated with treatment, non-adherence, relapse, incarceration, homelessness, violence, suicide, and poor prognosis. Nicotine dependence, you see it 70 to 90%. That's why I think it's so cruel, and I'll just go ahead and tell you, I think it's cruel that they put patients in this fire and then make them not smoke because they are, they have nicotine dependence. But I warn you, what's my opinion. So, but they do give them the patch, but it is just so difficult because they have it's just such a difficult time. And then substance abuse disorders the same way. A lot of them smoke. And they're trying to get off the cocaine, but they still can't have cigarettes. So that's one thing. You'll hear it. I promise you, you'll hear it. When you go to crisis, they'll hear it. Anxiety, depression, and suicide occur frequently if it's schizophrenia. Physical health illnesses are more common among people. It says that their life expectancy is less. And some of that is because, you may not, the staff may not realize that because they go to the emergency room all the time, they're frequent flyers, whatever, and so they may not hear what they're saying. They may not take it seriously. But then they don't take the meds. They don't take their psychiatric meds, so they don't take the diabetes medicine either. So, but this was interesting, y'all. Polydipsia, okay? It can lead to fatal water intoxication. It's indicated by hyponatremia, confusion, worsening psychotic symptoms, or who can remember what your normal sodium levels are? So what is something, what's creatinine? Is it creatinine? What do y'all, I had a 123 the other day, sodium level, a patient had a sodium level 123, and that to me is very clear. Usually 128 is what I can remember from way back, is considered a critical level. So sodium is very important because it does change your brain, it does change the confusion. And it's because it says here, they're so thirsty because of the antipsychotic meds cause the dry mouth. And then they have that compulsive behavior that is going to be doing something. And then the neuroendocrine abnormalities. So you will see as one of your interventions as a nurse is with patients with schizophrenia is to monitor their intake. Right, etiology. What is known is that brain chemistry, structure, and activity are different in persons with schizophrenia. There may be multiple inherited gene abnormalities that combined with non-genetic factors such as viral infections, birth injuries, environmental stressors, altering the brain's neurotransmitter. So y'all probably remember which neurotransmitter is for schizophrenia. That's the dopamine. All right, genetic. It's just saying that it may be, there may be some genetic potential. Then with the neurobiological, that was where I looked at I highlighted the dopamine theory. Remember the story, the first antipsychotic drugs are known as your conventional, your first generation antipsychotics. This is the Haldol and the Thorazine. These drugs block the activity of dopamine, receptors in the brain limiting the activity of dopamine, and reducing some of the symptoms of schizophrenia. Cocaine, Ritalin, and levodopa increase the activity of dopamine in the brain. Amphetamines can be used to induce a model of schizophrenia. Almost any drug abuse, including marijuana, can lead to schizophrenia in biologically vulnerable persons. Because the dopamine blocking agents do not alleviate all the symptoms of schizophrenia. So other neurochemical hypotheses. This is your second generation unconventional antipsychotic. Blocks serotonin as well as dopamine. And this suggests that serotonin plays a role in schizophrenia. So these are your second generation. This is your Giordano, your Latuda, your Seroquel, your Zyprexa. And the only third generation is Abilify, okay? Your brain structure abnormalities, disruptions in the communication pathways in the brain are thought to be severe in schizophrenia. So it shows back in, the first few chapters, it shows some changes with the PET scan in the brain. Reduced brain activity in the frontal lobe of a patient with schizophrenia. All right, your psychological and environmental factors. This would be your prenatal stressors, history of pregnancy or birth complications. It's associated with an increased risk of schizophrenia, poor nutrition, folate deficiency, hypoxia. It says other risk factors include a father older than 35 is the father's conception. It says funny, y'all, being born during late winter or early spring. I have no clue how you get that could be. Psychological stressors, stress increases cortisol levels, impeding the hypothalamic development. The family stress, just beginning college, moving away from one's family. Social, psychological, physical stressors. Environmental stressors. This is such as toxins. Part of the course of the disorder. You may see a forewarning or prodromal symptoms a month or so before. Schizophrenia is a chronic or recurring disorder that, like diabetes or heart disease, is managed but rarely cured. So this is how you explain to your patients. It's chronic, it's recurring, it's managed but rarely cured. So what do you do when they want to stop taking the medicine? Can you make them take it? You have to give them respect. You teach them, so you'll see what you teach the family and what you teach the patient. So see frequently private illness, the patients may be socially awkward, lonely, perhaps depressed. There may be difficulties with concentration, memory, completion of school. Prognostic considerations. For the majority of patients, most symptoms can be at least somewhat controlled through medications and psychosocial interventions. So we saw, one fellow told us last week that the medicine has finally got rid of the voices, but now he's so depressed. Because some of them will tell you they like the voices because it keeps them company, you know. But they don't, I've had them tell me before, I don't want to get rid of all of them, I just don't want them to be so loud. So, let's see, with support and effective treatments, many people with schizophrenia experience a good quality of life and success within their families. Schizophrenia does not respond fully to available treatments in most cases, leaving residual symptoms and causing varying degrees of dysfunction or disability. What you hopefully want to do is that you want to find, once treatment starts and you find a medicine that works, that you keep it level maintained so that they don't relapse again, because every time they relapse, it causes more damage to the brain, so, and they may not always get back that baseline again. So that's one reason why you want to teach and stress the importance of medication compliance. So phases of schizophrenia, you've got phase 1 is acute. This is when they see the hallucinations, the delusions, the apathy, the withdrawal, result of loss of functional abilities. Phase 2 is stabilization, and then phase 3 is maintenance. So ideally, recovery is reduced and no residual symptoms has occurred. So this is what you're hoping for, there's no residual. All right, under assessment, patients who may have psychotic disorder focuses largely on symptoms, coping, functioning, and safety. Assessment should also include a mental status exam along with a review of spiritual, cultural, biological, psychological, social, and environmental factors. Your pre-psychotic phase. Am I going too fast or not? Follow it. Second paragraph. Therefore, early assessment plays a key role in improving the prognosis of persons with schizophrenia. So this form of primary prevention involves monitoring those at high risk. So these are your high risk patients. This might be children or parents with schizophrenia, because you know that they be more prone to intervening to reduce stressors. Research suggests that each relapse of psychosis, there's an increase in the residual dysfunction, like I just talked about, and deterioration. And so, recognizing that the early warning signs of relapse is reduced sleep and concentration. So you always ask them if you're sleeping, and how many hours you're sleeping, how restful is your sleep. All right, now this, I want you to make sure you make yourself note cards on how you learn, but you want to make sure you understand the difference in positive symptoms and negative symptoms, okay? I will not, when you look on page 206, I promise you I will not pick out some of these terms, because God's are terms that, you know, I want you to just learn, you know, the main high spots, okay? Because there's no way, I mean, I don't know all these words, you know, every one of them, because it's just so many. So the ones that I stress will be the ones, you know, but just the definition of positive symptoms, back on 204. The presence of something that is not normally present, so that's what the positive symptoms mean. So that's your hallucinations, delusions, the bizarre behavior, the paranoia, abnormal movements. Most of your patients won't tell you they're acting bizarre. You usually get that from the families. You don't get it from the patients. Negative symptoms. Negative symptoms is the absence of something that should be there. This is interest in hygiene, motivation, ability to experience pleasure. So under positive symptoms, it's associated with acute onset. They respond well to medications. Alterations in thought. This is your reality. This is your delusions. Delusions are false, fixed beliefs that cannot be corrected by reasoning. So they have a delusion of offering evidence for, this is your, oh, good gracious, let me think about delusions. The one that says she's pregnant, that, God impregnated her and she's, that we've got one that stays pregnant all the time, she's probably 60.
We met her today.
Oh, yeah.
We met her today, and she got 50 bring back on the tax every month. She comes in on the 28th.
Okay. That's right. I bet that's right, I don't know that, that may be number one. I can't think of the name of the one. Okay, yeah, that's delusion, okay, in my opinion. All right, concrete thinking alterations of the comparability. I think your book has gone over, you've seen word salad before, when this is a jumble of words that's meaningless to the listener. And then, the epilation, I'm not sure I'm saying it right, but this is the one that the patient repeats what you say. That's ECHOLALI, you see it? And of course, no paranoid, it's just irrational fear of others. And hallucinations is just simply that. It's just on kind of the YouTube that I showed that night where they hear that people talking. Sometimes you ask them if they hear it, they'll tell you. Sometimes they hear it coming from the TV, coming from the radio. Sometimes they hear them talking to themselves, sometimes they talking to the patient. Now, I brought the movies if anybody wants to take one on hand of these movies, I know the test. All right, so there's a difference in command hallucinations. Command hallucinations means that the patient, the voices are telling them what to do, telling them to do something. So it directs the patient to take an action. They command the patient to either hurt themselves or to hurt others. So the one I saw the other day, his voices were telling him to hurt his sister. So see, under that Terrasol Act, you remember? I was obligated to call his sister and tell him. I mean, I didn't think he would do it, but I still called her to tell her, because I'm obligated to do that. And then, okay, the other word is, if they're not command hallucination, they're just, maybe something, that's another technical word. Sorry. Intrusive, maybe, it's just intrusive, they're just getting on your nerves, that's it, that's what's on my little check sheet, are they telling you things to do, are they commanding you to do things, or what they do? Negative symptoms. Negative symptoms develop slowly and are those that most interfere with a person's adjustment and ability to cope. Negative symptoms contribute to poor social functioning and social withdrawal. Affect. Affect is one of the terms that's on your mental status exam. It's that outward expression of a person's internal emotional state. Y'all seen patients with Parkinson's disease and remember they've got a flat affect. That's because of their disease process. Well, remember now, with schizophrenia, they also have that, confusion with the dopamine. So a lot of their expressions may be flat. They blunted. They may not respond. See, the flat is immobile. Blunted is reduced. You know what cognitive symptoms is. This is your memory, your attention. All right, affective symptoms. Affective symptoms, it's on page 208. This is the fourth group. Are common and increased patients suffering. Mood may be depressed, elated, unstable, erratic. Assessment for depression is crucial because it may herald an impending relapse. Increased substance abuse, increased suicide risk, further impaired function. I think y'all know what countertransference means under the self-assessment. So like it says, we work with individuals with schizophrenia produce strong emotional reactions called Counter transparency of most healthcare workers. Without supporting a willingness to explore these feelings with more experienced staff, the nurse may adopt non-therapeutic responses, denial, withdrawal, patient avoidance, and anger. Your assessment guidelines is that little green box. Yeah, you want to make sure the patient had a medical worker if there's a sudden change in their behavior. Assess for drug and alcohol abuse. Determine risk to hurt others. Ask them to combat the hallucinations. Assess the patients for delusions. A positive response to either of these questions suggests an increased risk of danger to others. See, assessment of ability to ensure personal safety. This is, they dressed appropriately for the weather, ability to move about safely, impulse control, judgment, integrity. On page 210, it reminds you again of those, the positive symptoms and the negative symptoms. Back on 209, the outcome identification. I think most of this you know this. Phase 1 of acute will be patient safety, stabilization. Phase 2 is helping the patient understand that illness and treatment become stabilized. Phase 3 is maintenance, maintaining achievement, adhering to treatment, preventing relapse. It kind of goes over it, repeats itself, So under the plan and acute phase 1 acute, the hospitalizations may be indicated, especially with the new onset of the hallucinations, especially if the patient is considered a danger to himself or others. Planning focuses on both the best strategies to ensure patient safety and control symptoms. Can schizophrenia be prevented? See box 12.2. This was really interesting. It was talking about supplemental essential fatty acids. And there have been some, it says, more studies are needed, but it's saying that omega-3 and omega-6 polyunsaturated fatty acids beneficial or can be abnormally low in brains of people with schizophrenia. So sometimes it's make it help them to take it. The bad part about it is most of them are on fixed incomes and they can't afford it. But then if it's worth a try. And there's some others, I'll try to remember to bring them next week, y'all. The list of some over-the-counter things. B12, some of the studies have shown that B12 may help. All right, box 12.2. Relapse prevention skills. Well, that's not it. See, box 2. Relapse, it's in here somewhere. Well, oh, there it is, on page, there we go, it's box 12.6. So it's on page 215. All right, number 1 is learn all you can about the illness. This is what you teach the patients, the families. Encourage them to join the National Alliance on Mental Illness. Number 2, this is what highlight. Develop a relapse prevention plan. Know the early warning signs of relapse, avoiding others, trouble sleeping, trouble thoughts. Make a list of who to call, what to do, and where to go. So relapse is part of the illness, not a sign of health. Encourage your families, if there is a support group for patients with schizophrenia, families with schizophrenia, to join a group. It helps when when they talk about it. Have a plan on paper what to do. Number 7, avoid alcohol and or drugs. They can act on the brain and cause a relapse. Keep healthy and stay in balance. Keep active, have hobbies. That's what's sad, they sometimes they live a life that, nobody wants to be around them. All right, so back on page 211, we've already talked about, we're still on phase 1, Q2, under interventions. Support, psychoeducation, guidance, supervision, monitor fluid intake. See, that's where you see the monitor fluid intake. And then under phase 2 stabilization, we're still working with medication administration, the adherence to meds. You want to be trusted in community-based therapeutic services. So family psychoeducation is a role, key role of the nurse. So see, that's one of your roles. You think about it when they come in with having a heart attack, that you want to go see the family, but don't forget it also when things are going on. Go see the family, talk to them. Teamwork is important. Activities in groups, teach them that they may find drawing, reading, poetry, journaling, listening to music. Teach constructive leisure skills, increase social skills. How to work with the aggressive patient. When the potential for if violence exists, measure to protect the patient and others become the priority. Interventions include increasing supervision, reducing stimuli, outlets for physical energy. All right, box 12.3 tells you how to have patients who are experiencing hallucinations. You don't want to refer to it as if it's real. You don't want to, it says do not negate the patient's experience, but offer your own perceptions. I don't hear the angry voices, but they must be very frightening for you. Focus on reality-based, here and now activities such as conversations or simple projects. So what you tell them, the voice you hear is part of your illness. It cannot hurt you. Try to listen to me and the others that you see around you. So you're just trying to be, calm and give them some other things to do. To think about. There have been a lot more studies on this counseling and communication techniques, therapeutic communication techniques. Delusions I highlighted until reality testing improves. It is never useful to debate or attempt to dissuade the patient from a delusion. However, it is helpful to clarify a misinterpretation of the environment and gently suggest a more reality-based perspective. So box 12.4 kind of gives you some other ideas, open, honest, genuine, and reliable, avoid debating. Associative looseness often mirrors the patient's idiosyncratic disorganized thinking. It increases anxiety. It says do not pretend that you understand the patient when you don't. This is the patient that can't answer questions, very vague, answers questions, you want to be blunt and just say, I'm having difficulty following what you're saying, you're not making any sense. Tell the patient that you do, tell the patient what you do understand, and reinforce clear communication and accurate expressions. So notice the themes. It's kind of like when they talked about that test question. All right, health teaching and health promotion. Education is essential and includes teaching the patient and the family about the illness, causes, medication side effects, what to expect, and relapse prevention. This helps the family. All right, now, we've got to really talk about the meds, okay? I know y'all ready to go. Y'all okay? No. The patient who returns to a warm, concerned, and supportive environment is less likely to experience relapse. So it's very important for the family to know their role is very important. All right, your antipsychotics, first generation. First generation, this is your Thorazine, this is your Haldol. On page 215, it goes into your side effects. I'm still back on page 214 because I wanted y'all to really hear this. All antipsychotics are effective for exacerbations and relapse prevention of schizophrenia. So the first generation antipsychotics act primarily on the positive symptoms of schizophrenia. This is your hallucinations, your delusions, your disordered thinking. The second and third generation antipsychotics can improve negative symptoms. This is your asociability, your one-to-day effect, your lack of motivation. And this is the second generation antipsychotics, if we can treat their negative symptoms, it helps the patient appear more, and they're just able to function better in society. Does that make sense? All right, all antipsychotics may increase mortality in elderly patients with dementia, so they're all probably on the leaders of this, and Beers criteria. No antipsychotics are addictive. There may be rebound effect characterized by temporary increase in the psychotic symptoms. They're all unlikely to be lethal in overdose situations. A lesser known risk of all antipsychotic meds due to dopamine blockade is impaired swallowing. So you want to make them all at risk for choking. Finally, persons with impaired cognition are at increased risk for falls. If you look on page 215, you'll see at the very end of the page where it talks about low potency equals high sedation plus high anticholinergic and low EPS. EPS is your extrapyramidal side effect. The high potency is low sedation plus low acetylcholine and high EPS. What I would suggest is the next two pages, 216, 217. All right, make sure you understand the anticholinergic toxicity. You see it in the middle of the page. So the dry mouth, for reduced raps and peristalsis. Mydriasis, which is what? That's your dilated pupils. Is that what that is? Dry, hot skin. What do you treat? What do you do? This is a potentially life-threatening medical emergency. So hold on medications, implement emergency cooling measures. Right, EPS. You see within 5 hours to 30 days, okay? This is the mask-like face. This is the stiff, stooped posture. Your acute dystonic reaction. This one you see in 1 to 5 days. This is the acute contraction of the tongue, the face, the neck. You may see the patient definitely like this. So you administer the Benadryl. And release usually occurs in 5 to 15 minutes. akathisia, you see within 2 hours to 60 days. This is that restlessness. It's the tapping the foot, rocking back and forth. You treat it with, it says propranolol, or your Ativan, or your Valium. See, tolerance to akathisia does not develop, but it usually subsides when the antipsychotic is discontinued. Or tardive dyskinesia. So I want you to make sure you understand tardive dyskinesia you don't see until the patient's been on the medication for months or years. This is what you do your Ames test for. This is that base, rolling tone that, smacking medicine in the nursing home. There's no known treatment. Nurses and doctors should screen patients for tardive dyskinesia at least every 3 months. Another one of your side effects that you may see with your antipsychotics is hypotension. So you teach your patients to sit inside the bed, change the position real fast. Remember we talked about clozaril in the past? Clozaril is a second generation antipsychotic, but it's used as a rule, it's used as a last resort, so it's used as for schizophrenia that does not respond to any other of your antipsychotics, because it's the one that you have to have weekly lab work, the agranulocytosis from low white count, the low granulocytes. All of the antipsychotics, they all have the potential for the metabolic syndrome, the weight gain, the elevated lipids, the elevated glucose. So you're really obligated to do some close monitoring. A lot of times, when patients find a drug that works, they'll settle for the weight gain, they'll settle for the others, as long as you monitor it. All right, table 12.5 on page 218. This is just another list of the medicines. Prolixin and Haldol, that's your first generation. We really don't see much stores in give it anymore. I've heard it's going to be back on because it's so much cheaper and a lot of these others are so expensive. All of them, Geodon is one of the ones that should not cause weight gain. Abilify is not supposed to cause weight gain. And the Geodon should not interfere with Alright, so I think I've told y'all. So like this page 219, I think most of it I've already talked about within the table on 12.4. So understand the tardive dyskinesia you don't see until the patient's been on the drugs for several months or years. So it's not something that you see right away. And what is it that you see right away? You see the EPS, okay? There's a difference. That you can see within 5 hours to 30 days. The acute dystonic reaction you may see within the window of 5 days. And you treat it with the Benadryl. And you may give an anti-Parkinsonate. That's your Cogen, and that's your Artane. Now still, it's on that last little paragraph on page, on the left-hand side of page 219. Your second generation antipsychotics are often chosen as first-line antipsychotics because they treat both the positive and the negative symptoms of schizophrenia. And they produce minimal EPS, or tardive dyskinesia. And unlike clozaril or other second-generation antipsychotics, they rarely cause agranulocytosis. However, with the exception of that's Geodon and Abilify. they have tendency to cause, other way around. The GNO and the Abilify do not cause wet down, okay, so that's, you see what it's saying, with the exception of GNO and Abilify. All the rest of them cause wet down. And see, they do the same thing with antibiotic syndrome. Alright, we talked about third generation antipsychotic, that's your Abilify. And we talked about anticholinergic toxicity. We didn't talk about neuroleptic malignant syndrome, it was not listed over here. So it is considered also a life-threatening emergency. And it occurs, for those who take the first generation antipsychotics, it can occur with second generation as well. It's caused by excessive dopamine receptor blockage. It's life-threatening, immediate medical emergency. It's fatal if it's not treated. So what does it do? Next page, 221. So you see reduced consciousness, increased muscle tone. Treatment consists of early detection, discontinuation of your antipsychotic, management of fluid balance, rapid temperature reduction. Adjuncts. Adjuncts to antipsychotics. The adjunct just means something some added. You may see antidepressants given for patients with depression. You may see mood stabilizing agents. This is your valproic, which is your Depakote. It's used during acute exacerbations to hasten the response of the antipsychotic. Lamictal may be given along with clozaril. Then your book talked about, I just highlighted this about the family therapy. You know, you just can't imagine how hard it is on the families to have an 18-year-old that's gets to go off to college and then has a sudden change and new diagnosis of schizophrenia. Now, if you can get your patient stabilized, they can go to college, okay? We've got one that's doing that. Okay, he's on Invega, he gets the Invega injection once a month, and he has, he's going to school.